Welcome to the Health Trip Podcast. My name is Jill Foose. I'm a functional medicine and integrative nutrition health coach. I created this podcast to bring you along as we travel down intriguing, science-packed roads, debunking old medical paradigms and perusing new innovative therapies and modalities with the finest functional medicine doctors, practitioners, and like-minded biohackers while living our best life. Enjoy the show. Hi, everyone, and welcome back to another episode of the Health Trip Podcast. Today, my guest and I are talking about all things related to perimenopause, symptom management, and why it is so confusing out there for women to navigate. Perimenopause is often described as a transition, but for many women, it feels more like being dropped into a gray zone with no map. Symptoms start showing up, cycles become unpredictable, moods shift, sleep falls apart, and suddenly women are being asked to make decisions about hormones without clear guidance or consistent answers. One of the most confusing questions women face is this: should I stay on birth control, switch to menopause hormone therapy, do both, or something else entirely? The internet offers opinions, social media offers extremes, and even doctors often disagree. Today's episode is about cutting through that noise. We're breaking down what's actually happening in the body during perimenopause, why this decision is so nuanced, and how women can make informed, individualized choices instead of guessing or suffering in silence. My guest today is Dr. Sarah Delatorre, a double board certified physician with over 25 years of experience dedicated to advancing women's health. A seasoned OBGYN, she has delivered over 4,000 babies, performed countless surgeries, and guided women through every stage of their health journey. Her passion for empowering women led her to expand her expertise into hormone optimization, functional medicine, and lifestyle-based care. She's certified in perimenopause and menopause care, lifestyle medicine, and functional medicine. Dr. Sarah also serves as the clinical lead for Respin Health, which is where her and I met. That is Halle Berry's platform for menopause lifestyle and community. And she's also contributed to women's health advancements with JoyLux, which is a red light therapy device that you use inside your vagina to help rejuvenate the tissue. And she is a clinical faculty member at the University of Washington School of Medicine. Just a short medical disclaimer before we dive in. By listening to this podcast, you agree not to use this podcast as medical advice or to make any lifestyle changes to treat any medical condition in yourself or others. Consult your own physician for any medical issues that you may be having. And this entire disclaimer also applies to any of my guests on my podcast. So sit back, open your mind, and let's dive into perimenopause. Hey, Dr. Sarah, welcome back to the Health Trip Podcast. The last time you were on, we dove into testosterone for women, and that episode number 104 was a massive hit. So I'm so psyched to have you back.
Great. I'm happy to hear that. And I'm so happy to be here, especially I loved our testosterone talk, but this talk today is also really near and dear to my heart too.
Yeah. So today, our goal is to clarify the options women have for navigating perimenopause through postmenopause. So this phase, as you and I know, of hormonal change can bring a wide range of disruptive symptoms, and the noise around what to do about them can feel even more overwhelming. So many midlife women, as you know, we are juggling work, family, caregiving, daily life, but we just want to figure out how to feel like ourselves again. We just want to function well throughout the day. And most are relying on their doctor's direction. And as you know, many doctors are not informed or have the training to help guide their patients.
It's so true. And I think it's easy for clinicians to just say, well, this is easy, just take this, right? For many clinicians, especially in the conventional world of here's a pill or here's this, just take this. And what that does is it lacks individualized care for a woman. So just as you said, women, we're dealing with our symptoms. We're dealing with midlife stress, teenagers, aging parents, work, you name it. And then now we're supposed to make complex hormone decisions. And then we're supposed to do that with very little guidance, right? So it puts women in a very difficult bind, I think. And birth control versus hormone therapy is one of the most confusing crossroads for women at this time, right? There's a lot of misinformation, a lot of outdated beliefs. And like I said before, just lack of individualized care. So I'm glad we're going to help
Yeah.
untangle some of that today.
Yeah. Why does this have to be so confusing for a woman who's in perimenopause?
It's a good question. I think for one, if you ask women older than us, you and I are the same generation, they would say, what is perimenopause? I don't even know what you're talking
Right.
about, right? So perimenopause was most recently, thankfully, defined. It was always sort of like periods, no periods. So you're like in before menopause and then you're in menopause. So it's a relatively new concept, even though it's not a new biologic or physiologic concept at all. But I do feel like it's confusing perimenopause, mainly because there's no clear start. It's not like you wake up one day and you're like, now I'm in perimenopause, and then now I'm in menopause, right? These hormones are fluctuating wildly for a very long time before periods stop. And then symptoms vary from person to person. So I might have migraines and insomnia. You might have bleeding craziness or libido changes or brain fog, right? So you can't sort of, clinically say this is the box of symptoms, right? So it varies. Hormone testing isn't helpful. So I think that can be challenging because people want to look at hormones and find a definition there. And
Wait,
then the
let's
other,
just let me
yeah,
stop there for just a second.
sure.
So, hormone testing is not the best way to go when you're in perimenopause. Should that be a red flag if you were with a provider, let's say even outside of the healthcare, like the health insurance model, if you're with someone, like a functional medicine practitioner,
Right.
and they want to do all this extensive testing, maybe even the Dutch test, is that a red flag that this person might not be well versed in what you need?
I would say I would hedge a little bit and say it could be. So on the flip side of conventional medicine, again, it's these black and whites, right? Conventional medicine being like, I'm not testing your hormones, it doesn't tell me anything, versus a functional medicine provider, and I'm both, right? I live in both
Mm-hmm.
worlds, being like, oh yeah, let's do all of this testing, and then I can tell you so much from this testing. I can't tell you anything from your progesterone level on, well, it's not that I can't tell you anything. I can't tell you much. I can tell you you're in perimenopause, right? If your progesterone level on day 20 is 6, right? I'm going to be like, oh, your progesterone's not doing very much, but I can tell you the exact same thing from your symptoms, right? So to me, hormone testing doesn't add. And I would say it could be a red flag, but I would, in that case, ask, just like at a conventional doctor, why won't you test my hormones? Like, I just think women need to have explanations for why
Yeah.
this provider is giving you this answer of like, why do I need to be on the pill? Why won't you test my hormones? Or why do I need to spend $1,000 on these tests? Right. So,
Yeah.
but good point. It is the more we go along, the more women will learn that one, they should listen to their bodies, and two, they should ask more questions of their providers, right?
Hmm.
And push
Hmm.
to get the information that they need. Yeah.
Yeah. And what about women being told they're just too young? You're just too young. You're
Yeah.
not in perimenopause. Like my daughter's 29, 30 is right around the corner.
Right.
Women are waiting longer to have babies. And,
Mhm.
that coincides with me, perhaps the start of perimenopause.
Right. And I think many women are dismissed. I would say probably 15 years ago, 10 years ago anyway, I would dismiss a woman that was like, can I be in perimenopause at age 35? I'd be like, no, are you kidding? I didn't even recognize my own perimenopausal symptoms at age 42. I just thought I was, which is what women are told often. I thought I was just stressed, and I was stressed, but I was also in significant perimenopause. And so women are dismissed. They're told they're too young. It's stress. It's their symptoms are unrelated, or they're imagining it, or you're just gaining weight because your lifestyle has changed. So yeah, so women are dismissed, and then they go online to find answers, and then there's those extremes that we talked about earlier, where it's like very dogmatic, and it makes it even more confusing. And I just think the medical system hasn't really caught up with how complex perimenopause is and how individualized it is.
Yeah. Yeah.
Yeah.
I was going through my divorce when I was in perimenopause.
Hmm.
And if I'm a mom of five. And so there are times now in my life that I think back to certain situations. They pop up in my head like a movie. And I'm like,
Hmm.
oh my gosh, that was definitely part of my perimenopause journey. Like, if I had a freak out over something that did not,
Right.
need to be
Yeah.
freaked out over. Right. And
Yes.
these images come back and I'm like, darn, I wish someone would have told me.
Yeah, me too, Jill. I
Mhm.
also went through a divorce and perimenopause, and I've actually told my ex-husband a couple of things of like, maybe maybe
Right?
some of the reactivity or some of the issues, and I mean, obviously it was always both of us in our interactions, but just sort of my responses to things, like I wasn't
Mhm.
my best self. And I wish I had known, because even if we would still have gotten divorced, just things would have felt different for both of us. And I think supporting women in midlife and recognizing that if you're extremely reactive the way you didn't used to be, or if you're exhausted, it could very well be perimenopause, and that just changes your quality of life with recognizing it, or potentially can by getting support.
Yeah.
Yeah.
So, one of the topics we're going to dive into is this conversation around women in perimenopause and taking birth control versus menopause hormone therapy or some type of combination in between. But
Yeah.
before we get into that, because we're sort of on this topic of divorce and overreactive reactivity, a lot of women are being prescribed SSRIs and SNRIs as
Hmm.
sort of the entry level medication
Yes.
to help them with their symptoms.
Yes. So I will be very upfront. I have a very strong bias against birth control pills in perimenopause and against SSRIs in
Mm,
perimenopause. Not that I would not prescribe them, not that I don't think they're applicable to some women, but I do feel that the model tends to be depressed or anxious. Here's a pill. Here's an antidepressant pill, instead of thinking about what could be going on that would make you depressed and anxious. Is it circumstances? Is it your progesterone levels? Is it your hormones? Do you have a long history of depression? And, just more, again, more personalized. And the same goes with the pill, but we'll get to the pill in a little bit. The other reason why I don't love SSRIs in general is because they can potentially change brain chemistry. And the long-term data isn't, even the short-term data, but the long-term data isn't impressive in terms of long-term solution of depression and anxiety. And I've had the personal or anecdotal experience in my own clinical practice of women getting on hormone replacement therapy and being able to very easily come off their SSRI, and having them say, "Gosh, I wish this had been presented to me as an option instead of just an SSRI." How do you feel about it when you talk to your clients?
yeah, that's a really interesting perspective because there's a doctor in Chicago. She's a psychiatrist and she sends me a lot of her patients. And she believes the way um, to help women in midlife who are feeling that anxiousness or that depression is to actually start on menopause hormone therapy. Because
Yes.
even if
Yeah.
she has to give them an SSRI or an
Yes.
SNRI, the dose is going to be a fraction of maybe what it would have been without helping support the root cause,
Yeah.
which is hormonal imbalance.
Yeah, that's
So
fantastic.
that
She
makes
and I
sense
are
to
aligned,
me.
right? That she and I are completely aligned. I would
Yeah.
rather start with the root cause. I would
Hmm.
look at lifestyle. I would look at hormone. I would try progesterone, maybe estrogen, depending on brain fog and energy levels. And then if we haven't reached where we need to reach, an SSRI is absolutely a great option. I just don't like the opposite. I don't like starting with the SSRI, which tends to mask a lot of feelings, numb them, and then also affect their libido or their orgasm potential, which is already an issue. So I think the side effects I don't love. I'd rather give a hormone that could potentially help libido, help energy, help mood, instead of flattening it. Yeah.
Hmm. Yeah. Yeah.
Yeah.
Okay, so let's start talking about the birth control versus menopause
Yeah.
hormone therapy and all the things in between. So you already said you're not the biggest fan of starting with birth control. However,
Hmm.
lately on the internet or on social media, I've been hearing a lot of the OBGYNs saying it's 100% the right thing to do is start with birth control because we're having these hormonal fluctuations, all of these symptoms in perimenopause, and taking birth control flattens all of it so that they aren't on this roller coaster. They're more just on this, you know, solid footing. And so you're
Right.
saying that's not your first line of treatment.
It's not my first line. It's definitely part of the conversation. So again, I'm not a dogmatic practitioner. I'm not like my way or the highway.
Yeah.
I believe, again, it's a conversation with a woman. And first, let's define what we're saying when we're talking about the pill. I think that's helpful because it can be confusing because people think the hormones that are in the pill are interchangeable with hormone replacement therapy. So when we say the pill, we're talking about a combined oral contraceptive. There are progestin only pills, which are commonly used for women who have a history of migraines or blood clots or, postpartum with breastfeeding. And people will call it, just as a side note, people will call it a progesterone only pill, but it's not. It's a progestin. There's no progesterone in it. But usually a combined oral contraceptive is a synthetic estrogen called ethinyl estradiol and then a synthetic progestin. And when I'm using the word synthetic here, what I mean is not bioidentical. So they're not the same as the hormones that your body makes. And in midlife, I think this is particularly important because I tend to favor using hormones that are more bioidentical, like, very like 17 beta estradiol, like estradiol and micronized progesterone, because that's what structurally is the same as what our ovaries are producing. And most importantly, the reason why I do this is because they behave differently than what's in the pill. So I think it's really important for women to realize that these are not interchangeable, they're not the same, and that you can't substitute one for the other. Do you want to add anything to that before I kind of go on to this, like take the pill and why that's sometimes a good option?
Yes,
Yeah,
I do. One thing that I've also been hearing is that progestins are bad for you. They're dangerous. They can cause cancer. They can cause all types of health issues. Except
hmm
young women starting at age, 15 and up take birth control, right? They take birth
right.
control whether to control acne or to help them with their periods or using it for birth control. So that's really confusing because women can be on oral birth control for like 15, 20 years taking a
But some would
progestin.
argue, should they? Some would argue, should they? That
Right.
there is some data. So progestins are not great for our insulin resistance. Some progestins can be androgen, meaning male hormone, even though we all have them, but male hormone promoting. Some are male hormone decreasing. There was a study out, I think 2 years ago, that showed that maybe the Mirena IUD, which is, or not necessarily Mirena, but the levonorgestrel containing IUD might be related to breast cancer. So there is some data out there about progestins and breast cancer. And, that's what the Women's Health Initiative was determined that perhaps we knew it wasn't the estrogen. Could it be the progestin component? So I truly believe that if I had a daughter, I would want her on an IUD because it is the lowest exposure of this synthetic hormone. I had an IUD for years. Because the other thing, Jill, is like there's no great options for birth control besides what the birth control pill and an IUD, right? So would I ever have a young woman in my life be on Depo-Provera? Absolutely not. It's a huge dose of a synthetic progestin. A low dose pill could be a little bit better. I'm very choosy about which progestin I've put women on in terms of which pill I put them on, because some tend to have more side effects and more negative potential health outcomes. And then finally, the IUD, I think, is the safest and best option for women, or a NuvaRing, again, so sort of a topical application and not going through the liver and not going through our digestive system. So that's my quick and dirty on the pill, but you're right. It doesn't make sense, right? And you think, whoa, women are on the pill, but more and more I believe in, especially in the functional medicine world, we're finding that the birth control pill isn't a great option for 15 or 20 years and what we're setting women up for later in life. Yeah.
Okay, so then there's better options for younger women, including women who are in perimenopause who want to avoid pregnancy,
Yeah.
that
Yes.
are safer.
Mm. So yes, I do believe that there are safer options. So women in perimenopause. So the biggest question, when we're talking about every woman should be on the pill. So I completely understand why a clinician would say, this is great, right? Because it does suppress ovulation.
Mhm.
It'll smooth out your hormones because it just kind of tampers everything down. It's kind of a little bit of like a hammer, and maybe one would argue you just need a tap. But birth control pills will completely override, as you know, all your hormonal fluctuations. It can help with heavy erratic bleeding, which is a really big deal in perimenopause, leading to anemia and exhaustion. It's great for endometriosis. It's our best option for endometriosis. And then, of course, it provides contraception. So if I have a woman in perimenopause, let's say she's in her late 30s, early 40s, and we are still worried about a pregnancy, then I will talk to them about an IUD. But again, the pill is familiar to a lot of people. It can
Yeah.
improve some of your symptoms. It can help with night sweats and hot flashes, and it can protect your bones. And then, really importantly, the reason why I think one of the best things about the pill is it does lower your risk of ovarian cancer and endometrial cancers, and that effect lasts even after you stop. So the pill is not all evil. I'm not in that camp, but I think it's worth the conversation of what are her goals? Does she need
Mhm.
contraception or not? What are her symptoms? What are her risks? Is she more likely to get a blood clot? Is she having migraines? There's lots of women who have worsening migraines or starting of migraines in perimenopause. The pill would be the worst thing for her to go on, right? So it's just, again, it's personalized. So it is not a one size fits all. And you can easily manage birth control with an IUD and still take estrogen, estradiol, and progesterone, right?
Yeah,
So
that was
there's,
another
yeah,
question I was going to ask you, right?
yeah.
Can you start menopause hormone therapy alongside birth control?
Oh, birth control pill or an IUD or
The whole range.
yeah, that's a good question. So if I was to get really creative with someone and let's say I don't think I would ever put someone on a birth control pill and progesterone, but I put people on progesterone and estradiol all the time with an IUD. I have an IUD still because I've been too busy to take it out. But I've been on progesterone and estradiol in my IUD for a long time because I happen to spot more often and bleed more often with my perimenopause transition. So I was tired of that, and the IUDs just kind of shut it down for me. So
Are there
absolutely.
nuances to the delivery form for a woman who has a progestin only ring in her, or if she's taking oral birth control, in terms of, is it an estrogen patch? Is it oral estrogen? Like, how do you know who gets what?
So in general, so one, I'd like to think about it as bioidentical or not, right? So again, the pill is the ethinyl estradiol is it's a very, very potent estrogen, and it needs to be to provide birth control. So it's a potent estrogen. It goes through the liver, as a pill, and any estrogen that goes as a pill, whether it's bioidentical or birth control pill, goes through first pass metabolism. That affects our clotting factors. That dries up certain proteins like sex hormone binding globulin, which binds our free hormones. That can lower testosterone. So when I like to explain this to a patient in a very patient friendly way of this pill on both sides of the estrogen base and the progestin base are going to have some side effects, right? Like if you're having midlife acne, that's going to help clear it up for you, where an IUD might make it worse. So it's really good to put all of this out on the table for a patient and talk about libido and fluid retention and water weight gain, what some people have with the pill. But to answer your question, I'm not a big I don't love oral estrogen or estradiol for women in midlife and menopause. I know more and more on the internet. There's practitioners coming out and saying, well, oral estrogen is not that bad. I feel like it can have a positive effect on our lipid panel, on our lipid profile, right?
Hmm.
Increasing
Yeah.
HDL and lowering triglycerides, or it can bump up triglycerides, but lower LDL. But there's other ways to do that, and it also can affect clotting factors. And I don't love it. So I'm more of a patch gel transdermal application or a compounded cream with a progesterone. And I think that works best for most women. And as you may have experienced or in talking with your clients too, a lot of women in early perimenopause just need progesterone. They just need 25 up to 100 up to 200 milligrams of progesterone orally. Um, and just to divide, and I know you know this, Jill, but just to dive into the oral progesterone versus,
Yeah.
vaginal versus a cream, the vaginal progesterone has, well, let me step back. So progesterone protects the lining of your uterus, right, from growing and growing. So we need to give progesterone when we give an estrogen in perimenopause and menopause. We need to make sure those are balanced. So a woman's at a low risk for getting what's called a uterine hyperplasia or overgrowth of the lining or cancer. So that works. That is most effective with an oral pill. You know that you're going to have control of the uterine lining. And my clinical and vaginal progesterone has been shown to be able to do that too. In my clinical practice, I've found higher dose of transdermal progesterone to also be effective, but you won't find that in clinical studies. And it's usually very like, oh no, don't use transdermal. But there is some room for transdermal progesterone. The problem with transdermal and vaginal progesterone is that it doesn't hit your GABA receptors in your brain as well. So it doesn't help sleep as much, right? And you know this. So
Right.
that's why I'm a big oral progesterone fan, is because most women are not sleeping. Most women are anxious. Most women are feeling sort of wired and, not in a good way because of the excess estrogen they have and compared to progesterone. Does that make sense? Did I explain that well?
Yeah.
Because I know you know this, but
Yes.
did I explain it well?
Yeah. Yeah.
Yeah.
So a woman who's on oral birth control, you're not going to give her additional oral progesterone, or are you?
I, you could, but I just feel like it's a little counterproductive.
Mhm.
And if she was having symptoms on the pill. So a lot of women, this is what I tell women. I've had a few of these patients this year who have come in and be like, I'm on the pill. I feel good. What do I need to do? I'm 47. I feel fine. And I say, well, what do you want? What do you want to do? Are you worried about being on the pill? Do you want to see what your body's going through? And this one woman in particular is like, I've heard progestins are bad. I want to see what's happening. And but then I've had another patient who has lots of symptoms. She's irritable, she's not sleeping well, her libido's terrible. So for her, probably that pill is probably not doing it for her, or is almost too much of that synthetic estrogen for where she is, or her body chemistry as she's getting into midlife. So that's someone that I would have you come off of the pill, see how you feel, and then decide what we want to do. I don't think I've ever started progesterone on someone who's on a birth control pill. I just think it's counterintuitive. If she's having symptoms, then it's probably just better to come off of the pill and give her lower dose hormones and more bioidentical hormones.
Hmm. Yeah,
Yeah.
you brought something up with two of your patients. The one who comes in and says, I feel great, but I'm
Yeah.
she's hearing all this stuff and watching social
Right.
media, listening to podcasts, and her friends are talking, and maybe she's gone to some local menopause event, and she's hearing all this noise out there, and she's wondering to herself, okay, I'm 47, I better go have a conversation, you know, what are my next
Right.
steps here?
Yeah. I think it's great that she's having the conversation. I
Hmm.
think I've had so many women come to see me lately who are doing quite well. They just want to know what they don't know, because exactly that. They're hearing things on social media and everywhere, and they are so confused and they don't know what's right for them. So I feel that it's my job to then say, okay, here are all the pros and cons of being on the pill. Here are the pros and cons of coming off and seeing how you feel and considering menopause hormone therapy. And I think just laying it on the table, then they can sort of feel what feels best to them. So this one particular woman is retiring um, in March. And I told her, I was like, let's not go off the pill right now. Like and she has a very high stress job. I was like, the last thing we need to do is disrupt things as you're finishing your career, right? Let's wait
Yeah.
until March, have you calm down from retirement, and then let's go off the pill and decide what you want to do then. Where another woman came off the pill and she still feels great. She came off, but she feels wonderful. I saw her yesterday and she said, I might need a little bit of progesterone. I'm starting to notice some sleep issues, but hardly anything. I said, I think you're doing great. We're really focusing on lifestyle and some supplements, and she's feeling awesome. So there's no reason to have to do anything, but I think the conversation is really, really worth everyone's time for sure.
So is that patient of yours who's retiring and or the one who came off the birth control and she feels great, are you having the conversation around menopause hormone therapy with her, even though she feels great? Like, could she not take menopause hormone therapy and feel great? Like, how many women do you see like that?
Well, as we know, 80% of women have pretty moderate to severe symptoms. So there's 20% of women, and I have them in my practice. They're older now. They're 60, 65, and they're coming to see me to say, did I miss the boat on hormones? Like, should I start them now?
Mhm.
And a lot of them say, I kind of breezed through. I didn't really have that much of a problem. And, so there is this, small cohort of women who don't feel anything. But I am still having those conversations, because the conversations then are oriented around longevity. They're oriented
Yeah.
around their bone health. They're oriented around their cardiovascular health and their brain health, and informing them about what they potentially would miss out on by not being on hormones, that it's not just symptoms, it's longevity. And so the woman yesterday who feels great, I know she'll be back. She's 47. I know she'll be back in the next 6 to 12 months because she has been educated now. She knows the earlier you start hormone therapy, the better protection for your bones and all of that. So yes, it is a conversation that shifts from symptoms to long-term health outcomes.
Yeah, that's a really interesting conversation. Wait, back to the woman who's just on birth control and she's
Mhm.
feeling great. I've been hearing a lot on the internet too from these OG doctors that they should stay on birth control, come off at age 52, wait a few months and see what's going on, and then, readjust if they should go on menopause hormone therapy. What is so magical about 52? And
Because because it's the average age of menopause for a white woman. That is the only
hmm,
reason that it's I don't ever like to disparage other people, but to me, it's so black and white and in the box thinking of like, here's the algorithm handed down from the powers that be, instead of just thinking critically and clinically in terms of the person in front of you. And then what are, conventional medicine has so long accepted the birth control pill as super safe, even though there's been studies here and there that say, is it related to breast cancer? I remember as a resident in the first couple of years of practice thinking like, are birth controls related to breast cancer? Like some studies say yes, some studies say no. Like, is there really a signal there? And so for the most part, we've said no, but is that because of the age of the women that are on birth control pills? Whereas if you have it in midlife, could it be more dangerous? Like these are the questions that I would have where I know progesterone is neutral to protective against breast cancer, estradiol is protective against breast cancer, and testosterone is protective against breast cancer, right? So I know I'm not giving a hormone that's going to cause a breast cancer. So that's one way I think out of the box. And two, I it's just um it bothers me because again, it's just so prescriptive. It's like every woman stay on the pill until 52 and then come off and then da 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 da. And then there is
right.
no talk about long-term health effects. And progestins protect bone as well as estradiol does, right? Or do progestins protect bone as well as progesterone does? Like those types of conversations. So again, that's where it goes back to that woman's risks, what's her family history, what is she
Hmm.
concerned about? Progestins are not as safe for our cardiovascular health because they can promote insulin resistance. So now I'm having a 50-year-old woman on a more higher promoting of insulin resistance when she's already moving in that direction anyway, right? So there's
Yeah.
just more things to think about than 52 is the average age for a white woman. That's not even taking into account um, anybody else besides American white women.
Yeah. Yeah.
Yeah.
And when do you have the conversation around testosterone? Is that during perimenopause? I've heard you should not take testosterone during perimenopause, that
Mm.
it's only going to work for women who are in postmenopause. Now, I've been on
Oh
it.
no.
I'm 57. I've been on it for over 25 years and it's helped me. Would I say
Yeah.
I feel like it's changed my libido? To feeling like I want to have sex all the time? Absolutely not. And so I
Right.
was reading some, research in preparation for our conversation today, and it was really saying how testosterone is not going to work for everybody. But I think the
Correct.
story out there is that testosterone is this magic libido
Yes. Yes. It
hormone.
is it is frustrating because this is another thing that we can talk about that's so confusing to women. Because women are like, well, what's wrong with me? Testosterone didn't work for me, right? Or I
Right.
had side effects. I can't go back on it. So there's a recent article, which you probably know what I'm talking about, in a prominent publication that was all about women on testosterone and they're running around like crazy wanting to have sex and they're working out all the time. And to me, that is such an extreme and not true narrative. That is a
Yeah.
small percentage of the population. So what the literature showed was that about 60% of women saw a benefit to their libido, right? Two-thirds of women were like, I noticed a benefit to my libido. And what I would say is, I would say that translates well into my practice, is about 2/3 of women, whether it's on testosterone cream, which is compounded, or a gel, which is FDA approved, or injections, which are the three modalities that I use. Most typically, I use injections and a compounded cream, that about maybe 60 to maybe 70% are like, and when we get to the right levels, okay, my libido's at least back. Like I'm more interested. I'm thinking about sex separate from having sex, or I'm just more interested. The same is true with the other effects of testosterone. I find that testosterone can be very promoting of good energy, of a positive mood, and then certainly muscle mass and building strength. And I would say the numbers are about the same for that. About at most 70% of women will say, oh my gosh, I can tell a difference. I'm more energetic. It's like a light bulb went off. And some women, it is very extreme. One of my best friends, when I put her on testosterone, she called me 2 weeks later and she's like, oh my God, where has this been in my life? Like I just like a light bulb has been turned back on. But I would not say that most women feel that way. They do feel a lift. Probably about 60 to 70% of women feel a lift. So I do use it in perimenopause. So again, recent patient, she just needs progesterone. She doesn't need estrogen yet, but her libido's in the toilet. And so we're going to try testosterone and progesterone first. And then when she needs estrogen, layer that in.
And so I know we talked about um, how hormonal testing isn't necessary during
Hmm.
perimenopause, but for testosterone, is it different? Do you want to see where they're at, or is it just based on their symptoms?
Well, it's a little bit more of a complicated issue because testosterone is a controlled substance. And you, we do test levels and we follow it. I would say if you took me outside of regulatory models, I don't feel like testing testosterone is all that helpful. It can be. There's some data that serum testing isn't the most reliable for testosterone. A woman needs to skip her dose that day, or be, if she's doing injections, be on the fourth day since her injection when she tests. She needs to be fasting and before 9 a.m. Right. And so there's parameters around it, but I do follow testosterone levels about for no longer than 8 weeks after they initiate, and then about every 2 to 3 months, depending on their response and depending on their levels. And I can tell you, Jill, out of, let's say, there's probably 2% of patients that are go higher than the standard reference range when they're on it. And then actually probably half of those, maybe, only 1% are truly elevated. The other 1% just use their cream the morning that they had their serum done. So testosterone testing is technically important right now. It's a controlled substance. Those are the guidelines. I would say that dosing, I am helped by the testosterone levels, but I don't think testing is quite accurate. So I really base mostly on symptoms.
Hmm. Okay.
Yeah. But
And one of the,
just by the way, I've had pharmacists, when I've prescribed, I've had pharmacists ask me, are you testing this woman before they fill the prescription? Are you testing this woman? Very diligently, almost like as if they would report me to the state medical board, if I said no. So it's a controlled substance and it needs to be, cared for in that way, and labs followed for that reason.
okay. Okay, great. I want to shift our direction to
Sure.
special populations that might deserve a little bit more
Hmm.
attention in terms of this nuanced um, conversation around birth control and menopause hormone therapy, which is
Yeah.
women with severe PMS or PMDD. And maybe you can define what those are and why they're different before we dive in.
Yeah. So, severe PMS or PMDD is, I mean, there's a technical definition and I should just have it on the tip of my tongue, but clinically, when a woman's life is significantly affected for 7 to 10 days or up to 2 weeks before her period, where, severe crying spells, panic attacks, severe depression. So, like, cannot function. Where many women experience PMS, where you have physical symptoms or emotional symptoms, emotional and mental symptoms, but it's not significantly affecting your quality of life, where a PMDD it is. These are special populations, and they should be treated as such. And that's a population where frequently we will put a woman on, or I used to put a woman on a birth control pill for PMS. And what it does is it stops the hormonal fluctuations, but she doesn't necessarily feel that much better, right? Synthetic progestins can cause irritability, they can cause anxiety. So again, it depends on that woman's individual chemistry. So if a woman needed birth control, she's been on the pill, her PMDD is great on the pill, I would not take her off until she was ready to make that switch. But progesterone, I'm starting to use more and more, even in younger women. I have a 14-year-old in my practice who is on a low dose progesterone because her PMS and her periods are so terrible. So
Hmm.
progesterone's a wonderful, safe hormone. And so it is used very effectively with PMS and PMDD. I also am a big fan of Vitex for PMS. It's an herb, and there's some reasonable clinical data that it can help women with PMS. So I use a combination of pharmaceuticals and then nutraceuticals like DIM or Vitex as well. Um, did that answer your question in
Yeah.
terms of, yeah,
Yeah.
they are special populations. And I think my bias again is body identical hormone therapy is, especially, transdermal estradiol and micronized progesterone is probably going to be a more effective route for a perimenopausal woman with severe PMS to take.
Do you ever think about someone's genetic makeup and how that
Yes.
might reflect how these medications will affect them? Because when I was young, I
Yes.
tried to go on birth control, and oh my gosh, it was horrible
Me
for
too.
me. I
Hmm.
bled so much. I
Hmm.
was irritated. I was moody. Like it was just a
Hmm.
really bad experience. And then so hence the five babies.
You're like, I didn't quite come up with another good option.
Yeah. Yeah.
Well, yes, I'm with you. I'm the same way. And I would say clinically, I've know there that happens. Some women are like, I love the birth control women pill, and women, especially now that I'm talking to so many women in midlife, they're like, oh, I could never take the pill, and that is an automatic clue for me of how they're going to respond to
Mm,
menopause hormone therapy. So it is genetically determined, whether it's like our CYP2, our SNPs, leading to our different pathways of how we metabolize estrogen. That's
hmm.
all significantly involved in this. And so if you are giving a high dose of synthetic estrogen, right, and a progestin, and the body just doesn't metabolize it that well. So yes, I do think about women's genetics a lot. I'm not doing a lot of testing on genetics unless they want to. I think it's fascinating, and I'd like to know
Yeah.
what's their ApoE and what's their COMT, because that tells me a lot about their how they metabolize in general or how they methylate. So yes, I find that very fascinating. And yes, I absolutely think it has a lot to do with how we metabolize our hormones. I know it
Yeah.
does.
Yeah.
Yeah.
And what about women who go into perimenopause early or early menopause or surgical
Mhm.
menopause? How does that affect the conversation, especially if they're in like their 20s or early 30s
Right.
around menopause hormone therapy?
Yeah. Well, I find it a particular medical and personal for that person tragedy when women are not put on hormones immediately. I had
Mhm.
a patient come see me. She's 38. She has BRCA gene, and she was going to have her ovaries removed. And so we saw me 6 months before the surgery. We had, everything sort of lined up. We were going to put her on estrogen in the basically as she came out of the OR. And one surgeon said, "No, you're not. You've got to wait 2 weeks." And another surgeon who she ended up going with was like, "Absolutely. We won't let you go home without it." And I've had too many stories of too many patients who didn't have that kind of care or it wasn't recognized that they were in significant early perimenopause and then early menopause. So much higher risk for cardiovascular disease, dementia, even things like gut health and just quality of life for these women. So they absolutely it should be discussed if you're having, especially surgical induced menopause where it's planned, right? There should always be a discussion about hormones and the safety and putting them on right away.
And does that include testosterone?
So interestingly, what I'll do, I'll test a woman's testosterone levels before she has surgery,
Mm,
and see where she is and see how she feels. So this most recent patient I was just telling you about, her testosterone levels weren't that great technically for a premenopausal woman. She and her husband had a great sexual relationship. And so we agreed that she would wait and see how she does after this. We put progesterone and estradiol in place immediately. And then she wasn't able to have sex for 6 weeks anyway because of, surgical,
Right.
post-surgical precautions. And then so far she's like, I'm good. Like I feel everything feels fine. Everything feels great sexually. Another patient, same story, but her sex drive and her brain, everything completely tanked, even though she was on adequate estrogen and progesterone. So we quickly added testosterone. So
And
that one I played by ear. Mhm.
both of these women just had an oophorectomy. They just had their ovaries removed, correct?
One had ovary and uterus removed, and one
Mm.
had ovaries removed.
Hmm.
So either way, they were on estrogen and progesterone, and then the one had all and testosterone. Yeah.
It's so amazing to me how unique this process is and our bodies
Yes.
are. And it's like testosterone works for someone and it doesn't work for another woman. And
Right.
why is that? So it's just fascinating to me. And you have to be as a clinician like yourself, you have to be so well versed in a plethora of options and combinations.
Mhm.
Ask the right questions, make sure that you're really understanding this woman's ultimate goal.
Right. I mean, that's the thing about where OBGYNs are getting, trashed a little bit and doctors are getting trashed. But if you think you have 20 minutes with a patient to figure all of this out and have a personalized conversation, it is literally impossible. So of course it's going to be like, oh, here, you'll just be fine on the pill. Right. And then testosterone being a controlled substance, very little training on how to give it. And a lot of this is based on experience. Like I've read the books, I've done the courses, all this stuff, but a lot of this is just years and years of listening to women and starting to understand patterns and what you're talking about, like their genetics, certain responses. So it's sort of like also intuitive of what a woman may need. And then it's ultimately her decision, but I can guide her in that way. And then the other thing about the testosterone, which we probably talked about at the other podcast, was
Mhm.
dihydrotestosterone, right? So like who's going to lose their hair or I shouldn't lose it, it's dramatic. Who's going to have hair thinning or a receding hairline, right? So I'm following DHT levels at a baseline because then I can predict, oh, you may have that side effect. So then we can preempt it with finasteride or saw palmetto, right? So all of these things matter. And it's, to me, very important that the woman understands and that my patient sitting in front of me gets what I'm telling her and she understands why we're testing these things and what the recipe is and how we can change the recipe to fit her particular state of being at the time.
And most clinicians don't even test DHT. I mean, and they don't even think about it.
Yeah, they don't even know about it.
Right.
Like they think about it for a man, right?
Right.
So Propecia or a 5 alpha reductase inhibitor, but for a woman, they don't even think about it. And that is entirely genetic based. Like you're either a big DHT producer, that enzyme's really active, or you're not.
Mhm.
And then what I found, which is even more frustrating, is for some women, I've had women who have their DHT very high. Their hair is great. No problems with their hair. So there's so many other factors that go into it
Yeah.
besides that, but at least can be a potential red flag that I can look for and then prevent any potential side effects or have the patient be really aware of to be watching her hair.
Yeah.
Yeah.
I've worked with many women who have had hysterectomies and maybe they're given estrogen, but they're not given
Mhm.
progesterone because their uterus is removed, so they don't have to worry about protecting that lining. Why is that something that they should have a deeper conversation about?
Well, I think again, clinicians, we're taught like we're just doctors are very difficult to change our minds, right? We're just taught a certain way and we kind of stick with it. And progesterone is one of those things that progesterone forever was just put in this very small box of it just protects the uterine lining. That's its role. It doesn't have any other role, but progesterone has very powerful and positive effects in the body. So it does protect the lining of the uterus, as we talked earlier, and as you mentioned, but it also is amazing for mood, for calming, for reducing anxiety, for helping with sleep, and so improving insomnia. So whereas estradiol is, I think, I talk about it as like our sassy hormone. It's our energizing hormone. It's our like, let's go hormone. Progesterone is our calming hormone. And when those are out of balance, a woman, everybody's talking about how important estrogen is. Well, if your estrogen's out of balance with progesterone, you're going to feel wired and tired and like you're not going to feel great when you have too much estrogen compared to progesterone. And so, yeah, I think progesterone is a wonderful addition. And as I mentioned earlier, I think that's oftentimes the first and only hormone many women need in perimenopause, and not just 100 milligrams, maybe just 25, right?
Hmm.
Compound a smaller dose.
Yeah.
Yeah. And maybe at different times during her cycle, right? She needs 100 during the luteal phase and she feels great on 25 during the follicular phase of her cycle. So again, it's these nuances, it's personalizing, it's having the conversation that I believe, and this is not just I I'm promoting this because this is what I do. I just think this is what women, I know this is what women deserve. This is the care that women deserve, are these conversations and education.
Yeah, when we don't get our sleep, we get nothing done. We cannot take care of
Oh,
ourselves. We cannot take care of our kids or work. Nothing gets done.
right.
You want to be on a body composition journey? Not going to happen. You want to,
Yeah,
meal prep? Not going to happen.
exactly.
So right. So we have to have these conversations, and we have to hope that clinicians are learning to have the conversations, and that women are feeling more empowered to go in with the questions that they want to ask.
Yeah, exactly. And I think, we didn't we talked about the birth control, and I think I could answer that question a little bit better about how do I know when to go from birth control pill to hormone therapy. So if a woman is cycling herself, giving herself a period, so she's coming off those those hormones for a week. That's a great time to say, how do you feel? Like, are you sleeping well? Are you having hot flashes that
Mm.
week? Is your libido, are you cranky? Is your brain not working? That week without a period or without a pill and you're having a period, that's a great perimenopausal symptom check of how do you feel when you're off those hormones. And a lot of women will say, oh, it's, you know, I'm just, it's because I'm off the hormones, but that's kind of how you will likely be if you go off the pill consistently. I think that's
Don't
important
a
to think
lot of
about.
women skip that week so that they never have a
Hmm.
cycle?
Right. But those women, some of those women still, something switches that that hormone level, what's in the pill just becomes too much for what they need. Or maybe again, it's the synthetic versus the bioidentical, or sort of the hammer instead of the tap. But women will come in on the pill and just be like, I'm so irritable. I'm not sleeping. My libido's in the tank. So very classic, even though they're technically having those hormones replaced, but they're being replaced by synthetic and not bioidentical. So that might be the switch that also happens in midlife with being on the pill.
Okay. Okay. Another thing that I hear on social media is
Hmm.
now this woman who was taking birth control, she's now on menopause hormone therapy completely. And her doctor says, okay, you can do this for 5 years. And after
Hmm.
that, you're done.
Right. So that's pretty outdated. We used to say, like, right after the Women's Health Initiative, or maybe right before, but right, certainly in the last 15 years, it was sort of for the lowest dose for the shortest amount of
Hmm.
time. And now more recent data has showed us that's not true, that adequate dose for an unlimited amount of time at this point. So no one is saying, Menopause Society, ACOG, no one's saying you have to come off your hormones at a certain age. It's like at 60 or 65, it's a conversation of, here are the risks, here's the current data and literature. What would you like to do? But again, when you come off of those, if a woman at 65 stops her hormones, her bones will start to decline, her cardiovascular risk will go up. So it's not like we've just avoided them. We've just put them off until you go off the hormones, until you no longer have that protection. Um, so it does require that conversation of, okay, what's your bone? What are your genetics for your bones? How are you supporting your bones? What are your genetics for your cardiovascular health? How are you supporting your cardiovascular health? Because estrogen is so protective um, for our longevity and those health issues.
Is it the same conversation for a woman who has been on menopause hormone therapy, like myself, for, 10, 15 years, um,
Mm-hmm.
way before, I'm 65. At 65, is that conversation the same as if it was for someone who more recently started menopause hormone therapy closer to that age?
Yes, the conversations are different. So what the literature that's hopefully coming out and has started to come out and will continue to come out is, what are the long-term risks of being on bioidentical, most commonly transdermal estradiol and progesterone, right? That's a very different hormone combination than what was studied in the Women's Health Initiative. So it's bringing up a lot of questions. For a woman who's 60 and older, gosh, I've been in menopause for over 10 years. Is it safe for me to start? Most likely it's safe for her to start with some caveats in terms of what are her lipids doing? What has her lifestyle been? But what are the benefits? The real question is, what is the benefit to a woman at 60 and older, that far away from having estrogen? Are we going to actually give her benefit by giving her estradiol? That's more the question. I feel more comfortable with the risks that it would be
Mm-hmm.
low, but I'm wondering, like, is this actually going to help her brain? Is this actually going to help her heart? And that is an unknown. So I'm very clear with my patients. I don't know if this is going to benefit you. And we need more literature and research about this. For a woman who's 58, just became menopausal, and she's going on hormones, her timeline is shifted to later, right? And so
Mm-hmm.
she has a longer window to consider her options. But I still believe that a woman who's 65, been on it, or for you, for example, you've been on it for 15 to 20 years, it's evaluating your risk profile. Like, what is your risk profile for breast cancer, heart disease, brain health? Again, just measuring that risk benefit profile, and for someone your age and been on hormones for a long time, there's no reason that I would say you have to come off of them. Right.
Yeah.
I do lower women's doses as they get older. They don't need as much, but it's all symptom based. And I shouldn't say that, not all symptom based. It's mostly symptom based, but also looking at their levels of estradiol to make sure that they are in a level that will be most likely giving bone protection and cardiovascular protection. And the data we have, which is limited, is having an estradiol level of at least 60, right?
Mm.
That we know at
Yeah.
60, we're getting bone and heart protection. Most women, I feel like, feel much better around 80 to 115. That's kind
Yeah.
of a sweet spot. But again, everybody's different.
Yeah, that's where I am, but I have osteoporosis and I have a deep family history of cardiovascular disease.
Right.
And also, Alzheimer's. I have one of the Alzheimer's
Hmm.
alleles, ApoE4.
Hmm.
And so I hear a lot on the internet as well that we should be taking menopause hormone therapy to prevent dementia risk. But the science doesn't really show that.
Yeah, observational studies, some of them show that, but not randomized control trial. And
Hmm.
and so the data is, I would say the data is mixed, but to me, there's no harm. There's no harm there. It absolutely does not show that estradiol causes harm to your brain. It may not protect you, but it doesn't cause harm. So it's like neutral to beneficial is the question. So for me and my personally for myself, I will not come off of my hormones until there is clear data that I am causing myself harm. And there is no clear data now that shows me that I'm causing myself harm. There's much more data that I'm giving myself huge benefit in terms of brain, cardiovascular, body composition, and gut health, and my bones. Right. So strong family history of
Yeah.
osteoporosis for me too. So yeah, I would say that I am under the bias that I do think estradiol started early enough will protect our brains, but I'm waiting for Dr. Moscani to prove that and
Yeah.
others, right?
Yeah.
But right now we do know that the data supports that it does not cause harm.
Yeah. I mean, I still
Yeah,
have some major brain fog moments. Like today I
I
got on
do
my
too.
elevator and I pressed floor 14 and I live on floor 8 and I have absolutely no idea why I did that.
Yeah, I had one earlier today that I just could not think of a
Right.
word. It kind of comes and goes, and my estrogen levels are great, right? I like them at a certain
Right.
place, and they are there.
Hmm.
So I don't know. I don't. That might just be like multitasking. Maybe we're just
Exactly.
distracted.
Right, right. And
Yeah.
yeah, that's the other thing. It's really hard to figure out what is exactly going on because there's never just one
Hmm.
thing. We're busy women.
Right.
We are doing so much at one time. We're feeling more empowered to do more things. We're
Hmm.
trying to be in our
Right.
best shape and look our best and feel our best. And um,
Right.
so it's just never one thing.
Well, I get asked that a lot too, because a woman's hormones might be so-called optimized, right? Like her labs look great, and but she's still having brain fog, or like with testosterone, her libido's still in tank, but her testosterone levels look good or even on the higher side, right? So then that comes down to the conversation of, one, labs are not everything, symptoms are more important, but also hormones are foundational, but it's alongside the foundation of lifestyle, right? So what's your stress load? What's your sleep depth? I think what's really important is inflammation, right? Insulin resistance, how much inflammation you have in your body, which is stress related. How fast are you running all the time? Just all
Yeah,
of those things affect how we feel, affect our libido, if our nervous system is constantly dysregulated.
right.
We are going to have brain fog, right? Even if we have a great nutritional foundation and we're on hormones.
Yeah. I just realized we didn't talk about vaginal estrogen. And
Oh,
yeah, is that something that women in perimenopause should start to, whether they're having symptoms or not, could it be also
yeah.
used as preventative?
Absolutely. It can be used as preventative. The way what I would say in my practice is I ask about vaginal dryness. I ask about orgasms because then that'll tell me about testosterone or vaginal estrogen use or DHEA use. But oftentimes when women first come to see me, it's so overwhelming to just be thinking about progesterone. And most women are not having that much dryness. But the women who are, I will absolutely start a vaginal product on, whether it's estriol and estradiol or DHEA and something else. But I do think it's something that women, oftentimes they're not having sex, so they don't know. So I talk to them about sort of what it feels like down there in general, and if you're feeling irritated or dry, something like that, then it's good to get on top of that early on. And that I put everyone on vaginal estrogen, right? So safe and so effective,
Yeah.
right? Yeah. But
Well, we're,
UTIs, right? That's another one. The
yeah.
women in perimenopause are having, yesterday, a woman with more urge, and that's definitely estrogen related.
Hmm.
So even though she's not having dryness, she's having more urge incontinence.
Yeah.
So estrogen related. So her receptors are asking for more estrogen in her
Hmm.
bladder. Yeah.
So we're at the end of our time together. Is there anything else that you want to share about this perimenopause chaos, this transition
Yeah.
that we may have
Yeah,
left out?
I really feel compassion towards women who are in this phase because social media is really powerful and it can be very positive, but it can be so alarmist and stressful. And this is true when it comes to politics or our health or anything, right? So I like to reframe perimenopause as not a disaster or not as things falling apart. It's just a shift similar to puberty, similar to pregnancy, if you've been pregnant or postpartum. There's these shifts that we go through. Our biology is shifting. And it's sort of in this new phase that required sort of an update, right? Updated support. And that it can be very confusing, but it comes from these outdated beliefs, outdated rules, education of our providers, but also this very oversimplified messaging. And then that makes a woman feel like her solution should be very simple, right? Or very just take the pill, for example.
Yeah.
So I would just reframe that women deserve really clear information, clearly individualized options, and then clinicians who listen. And if a woman's listening to her body and the clinician's listening to her, then women they're not going to just survive perimenopause, they're going to thrive in it, and they're going to come out
Yeah.
stronger and just healthy. Yeah.
Yeah. That's great advice.
Yeah.
Tell us where we can find you. I know that you're in Idaho,
Yes,
but you also work via telemedicine in certain states, and tell us all about that.
I do. Thank you. I live in Sun Valley, Idaho, and part-time in Los Angeles. And I am licensed in 7 states, I think, at this point. So Illinois, Ohio, California, Arizona. So states that you can find on my website. But if you went to my website, it's called Lumani Wellness, named after my boys' names. And then also at Respin Health and joylux.com as well,
Mhm.
because I'm the chief medical officer at those 2 places, those two
Yeah,
businesses. Yeah.
which is where we met at Respin Health.
I know. I feel so lucky that we met.
Yeah, we have
I love
such
your
an awesome
podcast, by the
team.
way, Jill.
Oh,
Yeah,
thank
I love your
you.
podcast. You have amazing guests and very informative. You ask very good questions and you make it very accessible for people. So I do think you're doing a
Oh,
fantastic
well,
job.
thank you. Yeah, I want to
Yeah.
know too. I'm on this roller coaster ride as well. Of course, I'm on the other side of the fence, so it's a little bit smoother for me now. But
Yeah.
yeah, it's never a stagnant moment. Like we're always evolving
Mm-mm.
and changing, and things are always coming up, and we need access to the right information.
Yeah. Well, you're doing an excellent job
Yeah. Well,
providing it.
thank you.
So
It was so good to
yeah, you're
see you.
welcome. Yeah, happy
Yeah.
holidays. I'll talk to you really soon.
Okay. Thanks.
All right, thanks. Okay, bye.
Thanks for tuning in. Thank you for joining me. I hope you enjoyed the podcast. Lifestyle changes can be hard and overwhelming to make. By building your support team of functional medicine doctors, therapists, and health coaches, you can reach your optimal health goals. Be sure to check out my other podcasts. Until we meet again, stay healthy.